Thank you, Mr. Chairman. Assalamu alaikum and good afternoon, everyone. Protected PCI has been a topic of interest for the last 1 decade at least. And this afternoon, we're going to very quickly discuss the following 3 main objectives. We're going to try and understand the trajectory of contemporary practice as it pertains to high-risk coronary interventions. We're going to try and understand the role, if any, of mechanical circulatory support devices in these cases, and perhaps understand how do we select patients for hemodynamic support. As our technical skills improve with time and the performance of our interventional devices improves, we tend to embark on increasing complexity interventions. And concomitant with this, there has been an increase in the use of hemodynamic devices. Understandably so, because patients with complex coronary artery disease undergoing complex interventions tend to have bad outcomes. This data from the NCDR registry is now 2 decades old, and it showed that patients undergoing complex PCI tended to have less procedural success and a greater risk of adverse events during hospitalization. They had more post-PCI MI, more need for urgent CABG, and a doubling in their in-hospital mortality. Fast forward 20 years later, the outcomes are very similar. This is an analysis from a very large registry, the e-Ultimaster registry of PCI with drug-eluting stents, that showed that patients undergoing complex coronary interventions have a doubling in any of the adverse events that is listed on the graph. And it appears as though the likelihood of developing these adverse outcomes is correlated with the complexity of the intervention. The more complex the intervention, the more likely they are to have unfavorable outcomes. Now note that this data is from patients with relatively preserved systolic function. Every once in a while, you're faced with not only a challenging substrate of complex coronary disease, but there are oftentimes hemodynamic confounders that make the overall situation unfavorable, like this particular lady who has critical triple vessel disease, had an LV-EDP of 33 at the time of the intervention, and markedly impaired LV systolic function on echo at baseline. These are the patients that have limited reserve who do not tolerate complex coronary interventions. These are the patients in whom hemodynamic support may be required, and these are the platforms that are currently available for hemodynamic support for your complex interventions. They are slightly different in their hemodynamic profile, but overall they tend to reduce myocardial oxygen requirements by unloading the ventricle and support systemic circulation to the important end organs, specifically the coronary bed. It is imperative to note that for you to derive the maximum benefit from hemodynamic support, these devices have to be implemented prophylactically, i.e., before you start your complex intervention, because if you use it for bailout indications, the mortality, as you can see, is substantially higher, up to 10-fold high. So let's look at some of these devices and the evidence base to support their use. First of all, let's look at balloon pumps. These devices are widely available. The role of balloon pumps to support high-risk coronary interventions was studied in the BESIS-1 randomized trial. This trial was a randomized study across 17 centers in the UK that looked at prophylactic use of balloon pump versus no balloon pump in complex coronary interventions in patients with impaired LV systolic function. They looked at the composite endpoint of death, acute MI, stroke, and the need for urgent revascularization from the time of discharge out to 28 days from the index procedure, and a number of pre-specified secondary endpoints. The investigators managed to randomize 150 patients in each arm. Looking at the primary endpoint, there is no difference between the balloon pump supported group versus the group without balloon pump support. There was no difference in any of the individual components of the primary efficacy endpoint. There were fewer procedural hypotensive and arrhythmic events in the balloon pump supported group. And if you look at cumulative mortality at 6 months, albeit numerically lower in the balloon pump supported patients, the overall difference was not statistically significant. The investigators then revealed their long-term follow-up data, and even though there was no difference at 6 months, out to 51 months of follow-up, there was a significant 34% relative reduction in death in the balloon pump supported patients, attributed to more extensive and therefore more complete coronary revascularization. The Impella device is the only device that carries an FDA approval for this indication, and the hemodynamic effect of this device is beautifully shown in this case report. This was a patient who had an occluded right and a critical left main, who had an Impella CP device inserted at the outset of the procedure. As soon as the balloon went up, there was a precipitous drop in the systemic and the left ventricular systolic pressures to the point of ventricular arterial uncoupling. Now, in a normal situation, a patient like this would arrest on your table. But because there was an Impella in situ, it continued to support the systemic pressures until the operator was able to finish the procedure and the ventricle recovered from its stunned state. The FDA approval came from the PROTECT 2 randomized trial, which looked at the outcomes of balloon pump-supported high-risk PCI versus Impella 2.5 supported PCI. They looked at composite endpoints at 30 and 90 days. In the intention to treat analysis, there was a trend towards fewer adverse events at 90 days. In the per-protocol analysis, that trend was seen early at 30 days and became quite significant at 90 days. The investigators then reanalyzed the data using more prognostically relevant definitions of post-PCI MI and showed that with the new MI definition, there was a significant reduction in major adverse events at 30 and 90 days, and a significant reduction in a combined cardiac and cerebrovascular events at 90 days. The use of the Impella device was an independent predictor of fewer adverse events at 90 days, and the effect was more pronounced in patients who had triple vessel disease with an EF cutoff of less than 30%. Those patients experienced fewer hypotension events during the procedure. There were fewer major adverse events at 90 days, and the use of Impella was an independent predictor of survival free of major adverse events at 90 days. Subsequent to this, there was the PROTECT 3 registry, which included patients that had more complex, more extensive interventions, and the use of the Impella CP was also studied in that context, and patients in the PROTECT 3 cohort had fewer adverse events compared to the balloon pump cohort and the Impella 2.5 cohort of the original PROTECT 2 randomized control trial. The tandem heart is another device that you can use to support your complex interventions. The evidence to support its use is less robust, mostly single-center observational studies. This was a meta-analysis looking at outcomes of Impella-supported PCI versus tandem heart-supported PCI, and even though tandem heart carried you to the end of the procedure, there was an increase in 30-day mortality in the tandem heart treated groups and an increase in the risk of vascular complications peri-procedurally. There are centers that use VA ECMO to support their high-risk coronary interventions, and yes, that's a viable and a feasible option. The evidence to support its use is even less robust. Small number studies summarized in this table, and the use of VA ECMO oftentimes comes at a hefty price tag of complications ranging anywhere from 40 to 60%, depending on the series you look at. The complications include vascular injury, limb ischemia, bleeding, acute kidney injury, and hemolysis. So therefore, it is important to note that the use of mechanical circulatory support is associated with increased risk of complications in your already high-risk complex procedures. And therefore, not every patient would benefit from the use of these devices. You have to go through a scrutiny. You have to carefully scrutinize the patients undergoing the procedures to identify who would best benefit from these devices. McCabe and his colleagues came up with a scoring system that relies on a number of clinical criteria, and in the sicker patients, some hemodynamic data derived from right heart catheterization that will hopefully help you identify those patients who would benefit from hemodynamic support during high-risk coronary interventions. And once you've gone through that mental process, the next step is to think of certain procedure-related factors that will help you select the best support device. So for example, a patient who has a mechanical valve and an LV thrombus will not be an ideal candidate for an Impella device. So the next time you think of your complex patient and a complex intervention, always think of the myocardial reserve available to support your procedure and the demands for your complex procedure, and try and identify the patients who really require mechanical circulatory support and select out the best device in order to achieve the best possible outcome. Thank you.
you.